Today's webinar is being presented by Dr. Dane Mosher. Dr. Mosher is a board-certified family physician, and like many people in the field, he began studying the treatment of autism after his son was diagnosed with the illness. Dr. Mosher was raised near Houston and has spent most of his life in Texas. He received his Bachelor of Science degree in mathematics from New Mexico State University, followed by several years working as a computer programmer in Austin and West Texas. In 1999, he changed careers, becoming the head brewer for an Austin area microbrewery. He later decided to pursue his long-standing interest in the health sciences and committed himself to a career of helping others by obtaining his doctorate of osteopathic medicine from the University of North Texas Health Science Center of Fort Worth. He completed a 3-year family medicine residency at East Tennessee State University in Kingsport, Tennessee, a primary care training program in an area of the country that sees a wide variety of pathologies. The teaching hospital in Kingsport has one of the busiest emergency rooms in Tennessee. His training there included pediatric outpatient and inpatient care, as well as time in the pediatric ICU. Dr. Mosher's professional interests include osteopathic manipulative medicine, functional medicine, which focuses on the diagnosis and treatment of the root causes of chronic disease, and urgent care medicine. Before we begin the presentation, please note that questions can be typed into your control panel throughout the presentation, and time permitting, they will be addressed at the end. Also, for those of you that have requested copies of the presentation, we cannot send out the presentation slides. However, we do post recordings of all of our free webinars on the Johnson Center YouTube channel. Please search for us on YouTube and subscribe to get full access of all of our recorded webinars. We are currently offering certificates of attendance for this webinar, and a link to complete a short quiz will be emailed to you following the presentation. Now please welcome our presenter, Dr. Dane Mosher.
Thank you, Anna. Good day, everyone. It's my pleasure to talk to you today about autism spectrum disorders and comorbid conditions. So, for those who don't know what comorbid means, it's simply a disease that is concurrent with another disease. So, this example that I've provided here is if you have diabetes and you develop arthritis, those are comorbid conditions. It doesn't necessarily mean that they are causally related, although they may be. This is the DSM-5 criteria for diagnosis of autism spectrum disorders. This was a recent update in the diagnostic criteria, and I'm not going to read this to you. What I find that this particular definition or criteria is pretty cumbersome to get through, and so what I've done is removed a lot of the unnecessary verbiage in the next slide and just left the words that I think are key to look at. Deficits in social communication, social interaction, abnormal conversation, difficulty with sharing, restricted interests, abnormal affect. These are the things that are important to not only pay attention to in terms of if you're wondering whether someone has autism, but also looking at these things for changes. Say you have a child who is on the spectrum and some of these characteristics start to change, perhaps worsen in some ways. For example, they may become aggressive, whereas before they weren't aggressive. They may start suddenly wetting the bed, whereas they weren't doing that before. They may become injurious to themselves. These are the things that I think are important to look at in context with what I'm talking about today, which is comorbid conditions, because sometimes other diseases can present themselves in someone with autism and it's not apparent that that's what's going on, and you have to look for subtle clues in their behavior to see if something might be going wrong. And we'll talk about more about that as the presentation goes on. So this is these are some statistics regarding comorbid diseases with autism. And as you can see, people who are diagnosed on the autism spectrum are much more likely to develop other problems, with gastrointestinal problems being quite significantly elevated in kids on the spectrum. This is a chart showing a study that was done among hospitalized children and young adults, and they looked at groups with autism and equal numbers of persons without autism, and looked for the prevalence of various diseases. And as you can see, in most cases, the patients with autism had quite a bit higher levels of these comorbid conditions. In fact, they are all elevated with the exception of autoimmune disease, with seizure disorder and bowel disorder and CNS anomalies obviously being the most pronounced. And we'll talk more about these specific diseases and what they might mean, how they might present in a child with autism. These are the ones. These were mostly listed on the previous slide. I'm going to go over each of these individually. So, how would you know if one of these showed up? A lot of times it's not as easy as asking the child or them telling you, my stomach hurts, my joints ache, I'm tired. Children with autism are not often able to express that, and sometimes not able to even perceive it in a way that they can verbalize. So you have to look for other clues frequently. So perhaps there might be head banging, and that could be because of headache, it could be because of frustration, it could be because of pain somewhere. You can see fidgeting, increase in hyperactivity perhaps related to some discomfort. Aggression is a common way to express pain. Pica, which is eating non-food items, is commonly represents a nutritional deficiency somewhere. And food refusal. They may understand on a gut level, literally, that a certain food is giving them an upset stomach or diarrhea, and suddenly they stop eating it. But they don't necessarily express that to you verbally. So you have to be on the lookout for these things. And this is why it's so important to look for these things, because you could have a serious illness missed or misdiagnosed for a long time. And not only is that a problem for anyone, because generally there's some sort of treatment available to fix the issue, or at least provide some level of comfort. But at the same time, by addressing that comorbidity, usually you have an impact on the core symptoms of autism. So let's start out, and we'll talk about genetic disorders. It's certainly, we don't have the time in this presentation to go over the spectrum of genetic disorders that could occur. In fact, I don't know that anyone would have the time to go over that, because there's new ones being found every day. As genetic testing is becoming more detailed and more precise, we're finding subtle genetic issues frequently now that have perhaps never been seen before, never been described before, and which is very exciting. It's also very daunting as parents and clinicians to try to figure out what to do with that information. But any child on the spectrum, it's reasonable to do some genetic testing, and insurance is paying for it more and more. An interesting thing about genetic testing is that where there are now some of these new findings, for example, perhaps a small chromosomal deletion on a particular chromosome has been found, and you wonder, what does that mean for my child? The geneticist says it's probably related to the developmental delays, but what do I do about it? Well, there actually are some parents getting together who share that common finding and forming very small groups online and sharing information about their child's symptoms and perhaps treatments that have helped, perhaps keeping each other updated on the latest research on that chromosome and what that particular gene might do. And I think it's very exciting. It's exciting that there may be some interventions that you can implement now in some cases, and certainly as time goes on and we learn more about specific genes and their function, I think that, additional interventions are bound to keep coming. Sleep disorders are very common. 80% of children with autism spectrum disorders have some sort of sleep problems at some point. And just like with anyone who has a sleep problem, it could lead to problems with concentration, inattention. It could make you aggressive. It could affect your mood. It could make you anxious. It'll affect your immune system. So these are things we definitely don't want to ignore. This is actually one of those comorbidities that usually is not ignored because it usually affects the whole household. I'm going to move on. Causes of sleep disorders. Hormone imbalances can certainly do it in growing children. If it's something that's a new onset, in other words, a sudden change in sleep patterns, it may be more likely to some sort of pain or discomfort, and GI disturbances are a classic source of those problems. Seizure activity certainly can do it. New medicines, especially psychiatric medicines, are quite likely to interfere with sleep. Sleep environment, of course, is important because there's many children nowadays who fall asleep with the television on or with some sort of screen on in their room. They're not in a dark environment. They've got a lot of night lights on because of various anxieties and such, but those lights do interfere with quality sleep. And sleep apnea is a concern for any child with sleep problems that can't be traced to anything else. Usually sleep apnea in a child is related to enlarged tonsils or in some cases obesity, or perhaps some sort of sedative effect from a medication. I'm going to move on to gastrointestinal symptoms. This study showed that children with autism spectrum disorders are 4 times more likely to have GI complaints than the typical child. I've also seen studies that show much higher than that. So I think 4 times is probably a conservative estimate. And as this study showed, you may not be able to know what's going on until you notice that there's an escalation of aggression or self-injury. So what else would be happening besides abdominal pain? Chronic constipation is certainly something that could be missed. A lot of parents, especially as their children get older, are not even aware of when their kids go to the bathroom anymore because they're independent. So you might have to ask or do a little bit of investigative work to figure out if there could be some constipation going on. Small, hard stools, straining while he or she is using the bathroom. These are certainly signs of constipation. Or if you happen to get a glimpse of a bowel movement and you see food that the child ate 3 days ago, that's another sign of constipation. Chronic diarrhea is usually a little bit more easily found because there's more signs of it in the toilet, and the child is going to the bathroom frequently. It's usually not as easily missed. Reflux is something that could be missed because there's no outward symptom. That would be something that might need to be diagnosed by a gastroenterologist. And then there's a non-specific abdominal pain. There's bloating, flatulence. Failure to grow certainly would be a sign of some sort of nutritional or malabsorption problem that could be related to a GI disorder. Let's talk about seizure disorders. This is likely the most common comorbidity. Estimates of children on the spectrum with some sort of seizure disorder I've seen as high as 30%, with abnormal activity without an actual seizure being as high as 50 to 70%. So there are the classic seizures are divided up into grand mal, simple partial, complex partial, and absent seizures. And I'll talk about those briefly. Grand mal seizures are probably what most people think of when they think of seizures. This is the kind that completely incapacitates a person. They fall to the ground, their whole body is shaking and clenching, and they are unconscious for quite a while afterwards, and they have no memory of the event. Frequently there's a loss of bladder control, sometimes tongue biting during the event. But there are a lot of other types of seizures that you may not know about. A simple partial seizure is a seizure that affects only one part of the body. Commonly it might be an extremity or an area of the face, and you would only get the muscle contractions and spasms in that area of the body only. And when you say it's a simple seizure, it means that it's not affecting the consciousness. The person is completely conscious throughout it and is aware of what's going on. Complex partial is a seizure that also affects only part of the body but also affects the consciousness. So there will be a loss of consciousness in that case, and unlikely to be a memory of the event. Absent seizures are the one type of seizure I think that is most likely to be undiagnosed, because the others tend to be a little more obvious. But absent seizures are seizures that are characterized by spacing out for about 10 seconds at a time, just perhaps staring into space. There might be some facial tics at the time, but the child is typically unresponsive during that time, and usually does not remember the time they were having the seizure, and it can happen many times per day. Kids with absent seizures typically have academic issues at school. They're frequently blamed for their inattention, even though they're actually having seizures. And studies have shown that kids with absent seizures tend to have lower self-esteem and decreased abilities to do problem solving. So certainly a good thing to know about and to look for, because it can be treated with seizure medication. And then there's the large spectrum of abnormal electrical activity without seizures. So commonly a child will get an electroencephalogram, an EEG, through a neurologist's office or at a hospital with a neurologist overseeing it. And not always, but sometimes the neurologist will say, well, we saw some abnormal electrical spikes in a certain area of the brain, but it's not a seizure. And commonly a neurologist will say, well, there's nothing to do about it. And that's probably true most of the time. However, if you have a child who's nonverbal and those electrical spikes, which are abnormal, are occurring in the left temporal lobe where the brain's speech center is located, then you might want to think about trying to do something about that. There might be a benefit to getting that electrical activity under control with a anti-epileptic medication. Of course, that's an individualized decision, not only the parents, but the doctor as well, because a lot of doctors are not going to be comfortable prescribing a medicine that has a lot of potential side effects to a child that's not actually having seizures. But it's something worth discussing if this is what's going on. Muscular dystrophies, this is a fairly rare finding in the general population and in the autism spectrum population, although it is more common in the autism spectrum population, so I'm going to discuss it briefly. It's typically a genetic disorder involving the muscle. There are several varieties of muscular dystrophies, but they typically involve abnormalities in proteins that are involved in the structure of the muscles. And so you typically will see muscle weakness as the primary symptom. Some varieties will start in the center of the body and then slowly spread to the extremities over time. Some start in the extremities and spread centrally. Some are primarily limited to the face. And it's hard to generalize these things, but anytime you see an obvious muscle weakness, you need to get testing to see if this could be going on. These diseases are typically inherited in a autosomal recessive fashion, although some are also on the X chromosome and therefore affect primarily boys. So you can have both. So parents typically are not going to have the symptoms because they're not going to have two copies of the defective gene. They each might have one copy, and then the child was unlucky enough to get both of those bad copies. So if you do have a child with a muscular dystrophy, most likely you've already have seen a genetic counselor if you were thinking about having more children, because certainly it's a possibility that you could pass this on to future children. Nutritional deficiencies. This is fairly common in the autism spectrum population, and probably because a lot of kids on the spectrum have a very limited or a picky diet. It may be just a handful of foods they prefer to eat and they won't eat anything else. Sometimes it's difficult to get a child on the spectrum to eat vegetables. You have to figure out ways to sneak it into their diet. For all those reasons, nutritional deficiencies are pretty common. A lot of kids on the spectrum don't necessarily like being outside playing. They prefer more to be inside looking at books or looking at iPads or whatnot, and therefore they're not getting a lot of vitamin D from the sun. And then there's certainly a possibility that there's truly a metabolic difference in the child, and they require more of a particular nutrient than an average person would. So you really can't know what kind of deficiencies someone is having unless you get some lab testing done, or you have a dietitian analyze the nutritional content of their diet by looking at a food diary, or some doctors and nutritionists are experienced at looking for signs of deficiency on a physical exam and may be able to diagnose some things that way. Common deficiencies are B vitamins, some minerals like zinc, magnesium, iron, sometimes selenium, rarely copper, but you sometimes see that. Vitamin D, as I said, and then protein and amino acids, and especially in kids who either have a malabsorption problem or they're not making enough digestive enzymes to break down the protein they're eating, or they're just eating a low-protein diet. Antioxidants are commonly needed as well. Pica, the eating of non-food items, is you certainly suspect a nutritional deficiency if you see that, although it's not specific necessarily to a particular nutrient. I think zinc and iron are commonly suspected in that, but it's never been conclusively shown that it is definitely due to those deficiencies. Replacing any deficient nutrients can have dramatic effects. You know, sometimes children who weren't talking suddenly start talking. You can see amazing things when you address these. This is a complicated subject here. This is mitochondrial disorders and diseases, which really are when you say disorder and disease, it's the same thing. This is a wide variety of diseases that affect mitochondria, which are the energy-producing organelles of the cells. These are tiny little energy factories inside most of the cells of the body. They're actually most likely some sort of bacteria from long ago that formed a symbiotic relationship with animal cells, and so they actually have a different DNA genome than what we think of as our DNA. There's mitochondrial DNA and somatic DNA, and those are not the same thing. So a mitochondrial disease affects the production of energy in the body. We're talking about ATP, which is the primary energy currency of the body. And so when you have a reduced supply of ATP, you can have a tremendous range of effects, and it can affect everything from your ability to perform academically, because your brain gets tired. It can affect your ability to produce insulin because your pancreas doesn't have the energy to do it. Your muscle tone tends to be low. You tend to be physically fatigued with exercise pretty easily. But there's not any one particular pattern that you'll see with a mitochondrial disease, because there's a lot of different causes of mitochondrial problems. Kids who have mitochondrial disease and autism spectrum disorders are more likely to have regressive autism. In other words, they're more likely, instead of just being slow to develop, they may have been normally developing and then suddenly regressed. And that usually occurs within 2 weeks of having a fever for whatever reason that might be. There does appear to be a higher prevalence rate of mitochondrial disease in kids with autism than the general population. There's only been a few small studies looking at this, but it looks like, one study that I saw, it looked like about a 7% prevalence rate of kids on the spectrum have this. Most mitochondrial disorders are likely to be genetic, and there's because the mitochondrial DNA is not as well understood as the somatic DNA, we're still trying to figure out all the different ways the genes can affect the mitochondria. But one thing is that many of them do not respond well to current treatment. There's therapies that can help. Exercise actually helps frequently, but in terms of medicines to treat it, there's not always a good one out there for everyone. Then there's what's called mitochondrial dysfunction, and this may be slightly different than a mitochondrial disease in that sometimes what you find is a mild mitochondrial issue, and this could be caused by environmental factors, or perhaps a combination of environmental factors and someone's genetics. And these are often treatable with supplements and dietary changes, as well as therapies like exercise. And there are companies working on medicines to treat mitochondrial disease, and that's going on right now. Autoimmune diseases are, according to the graph I showed at the beginning of this presentation, are actually not more common in patients with autism than the general population. However, diabetes type 1 is more common, and diabetes type 1 is actually a form of an autoimmune disease. It's an autoimmune attack of the pancreatic beta cells, and so that's certainly what we'll look for. You know, if you have a child that suddenly starts peeing frequently, thirsty all the time, losing weight, hungry all the time, and it appears pretty dramatic, then get that child checked out. Have their blood sugar checked, maybe perhaps have their insulin level checked. Autoimmune thyroiditis is a common autoimmune disease found in the general population, and likely is just as common in the autism spectrum population. I don't have specific statistics about it, but if your child suddenly becomes tired, sleeping a lot more than normal, perhaps even a little puffy in appearance, complaining of being cold suddenly, always wanting it to be hot in the house, constipated, and you notice some dry skin or brittle hair, then certainly that's a sign of a low thyroid condition, and you might want to get a thyroid test done on the child. Sometimes with an autoimmune thyroiditis, though, you do get a temporary high thyroid state or hyperthyroidism before the low thyroid state sets in. So a high thyroid state is kind of the somewhat the opposite of the symptoms I just mentioned. The child will tend to be hot. There usually is not frank diarrhea, but the bowels might be a little loose. They might have a little bit more energy than normal. They might be a little tremulous. There can also be some muscle weakness in a hyperthyroid state. The next autoimmune disease I wanted to talk about is called PANDAS, which is short for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Group A Strep. This is still somewhat of a controversial diagnosis, although most people are in agreement that it does seem to exist. What not everyone agrees with is whether it's truly an autoimmune disorder, but there is definitely some evidence out there, especially from animal studies, that it is an autoimmune disease. And based on the treatments that seem to work for it, it is consistent with an autoimmune disease. And what it appears to be is a case of molecular mimicry, where antibodies that the body produces to fight a streptococcal infection then go on and perhaps cross the blood-brain barrier and affect the basal ganglia of the brain and cause severe psychiatric symptoms, usually anxiety, especially separation anxiety, and obsessive compulsive tendencies, and sleep disorders. And it's usually an abrupt onset when this happens, and then it will fade over time. But if someone has this sort of response to strep and they have an ongoing strep infection that's not being addressed, then those symptoms are not likely to go away anytime soon. So if you do see a sudden onset of obsessive compulsive behaviors or separation anxiety or sleep problems, you need to think about this. You might want to have their doctor swab their throat and look for strep throat, look for possible skin infections that might have been overlooked that could contain strep bacteria. The other autoimmune diseases that we normally think of when you say autoimmune disease, things like rheumatoid arthritis, lupus, mixed connective tissue disease, and so on, these are things that are probably not more common in the autism spectrum population, although certainly can happen. So you don't want to dismiss your child if they're complaining of their joints hurting, or especially if you see a joint that is appearing red or hot. That is definitely worth some attention. Anxiety and mood disorders. These are definitely more prevalent in the pediatric autism spectrum population, although a lot of times they're dismissed as part of the autism spectrum, and that's a tricky thing to tease out. Is obsessive compulsive tendency, is it part of normal autism, or is it actually a disorder? And you really need a trained professional to help figure that out. These are the prevalence rates of the various anxiety disorders. And on the next page, we talk about depressive symptoms. Depressive symptoms definitely seem to be more likely in children with ASD, especially higher functioning adolescents. Perhaps they're more aware of how they are different from their peers. Perhaps they're exposed to bullying and teasing. But it's more difficult to diagnose because the affect of a child with autism is not normal to begin with. So if they don't kind of give you those familiar facial cues that you look for in most people to see if they're depressed, if those aren't there, It might be difficult to determine if they're actually depressed. So you might have to look for some of the other signs of depression that are more subtle, like insomnia or excessive sleep or loss of appetite or not interested in doing the things they used to like to do. There has been a study looking at suicidal ideation and attempts among kids with autism, and they are higher than the average child, but they're not quite as high as the average child who's diagnosed with depression. But they found certain subgroups of autistic children that were more likely to be suicidal, and that was older age, minority status, lower social economic status, and being male. It doesn't look like anyone has got data yet about whether successful suicide attempts are higher in kids on the spectrum. Just thoughts of suicide and attempts. So you certainly don't want to dismiss this if your child brings up the idea that they want to kill themselves. It needs to be taken seriously, and it probably needs to be brought to the attention of a mental health professional. Learning disorders. This is something more common in kids on the autism spectrum, but again, this is sometimes difficult to differentiate from the autism symptoms themselves. Dyslexia is difficulty with reading. Dyscalculia is a difficulty with numbers. Dysgraphia is a difficulty with writing. Dyspraxia is a difficulty with movement. Auditory processing disorders, difficulty integrating information received through the ears. Visual processing disorder, difficulty integrating visual information. And then nonverbal learning disorder, which is a very subtle learning disorder. This is difficulties that don't involve written or spoken language, perhaps difficulties with problem solving or staying organized, while language skills appear to be good. And this is extremely hard to differentiate from a mild Asperger's type picture. But all of these things are treatable. There's not yet a consistent diagnostic standard for these, though, and the diagnoses are usually done in a school setting, and the criteria right now vary from state to state. So what I've talked about is not an exhaustive list of every disease someone on the spectrum can have, but be aware that kids on the spectrum can get sick with other things, and then perhaps they're more likely to do so, and you need to be vigilant to look for those things. It's easy to dismiss new symptoms like, oh gosh, this is part of the autism process, and that's not necessarily the case. And so, if you have any questions at all about it, I would have your child seen by a doctor who could evaluate for these comorbidities. And when you address the comorbidities, frequently the core symptoms of autism do improve. They become healthier in general. They're more likely to sleep better. They're more likely to learn. Their cognition is more likely to improve. So this is a very important thing to be on the watch for. Thank you for your time. I have finished a little early, so we do have time for questions. Let me see. Let me look at some of these questions and see if I can answer some of these. Well, this is an interesting question. A well-respected professional in autism told me that the latest theory is that there is no ASD without a comorbid condition. Would you say that is true? In my clinical experience, I would agree with that. That definitely seems to be true. There's definitely at least either nutritional deficiency or a gastrointestinal problem that I have found, but usually I find multiple comorbidities in most of my patients. Does iodine deficiency play a role in autism? That's I think the jury is still out on that. Dr. David Brownstein certainly is a believer in that, and he's a big proponent of iodine replacement. I don't know that there's been any studies done yet on iodine supplementation in autism, and I don't know that there's really been a consensus as to how you diagnose iodine deficiency. But my suspicion is that iodine deficiency is fairly common and probably is related to a lot of thyroid issues in people, but perhaps even more than that. So my thinking is it's a possibility. I sometimes do recommend iodine supplementation, but whether it's a causative factor in autism, I don't know. Here's someone who is curious if I have seen a comorbid eating disorder with autism. I cannot recall ever seeing a case of classic anorexia or bulimia in any of my patients. Although certainly picky eating can be extreme to the point where I have seen some children in an inpatient setting going through feeding therapy who refuse to eat even for up to 1 week because they're not getting their preferred foods, and a gastric tube was there, a percutaneous gastric tube was placed so that this child could be fed through a tube. So is that an eating disorder? I don't know, but that's pretty extreme. What role does hypothyroidism have in gastrointestinal symptoms? Hypothyroidism is going to slow down metabolism in general, and it does slow down peristalsis. So you're going to get an increased transit time, and you're going to be more likely to be constipated. And sometimes that then therefore can have further effects. Constipation is more likely to lead to perhaps a dysbiosis in the bowel as toxins are, lingering in the colon waiting to be evacuated. And of course you can get abdominal pain that may not be easily discovered in someone who's nonverbal. So hypothyroidism definitely does have gastrointestinal effects. I have a question here. What do you do about the GI problems? I haven't found a doctor that recognizes the gastrointestinal symptoms, disorders due to autism. My son has had this all his life. He is now 16. What you need, he needs testing. There's no one-size-fits-all treatment for GI problems. It depends on what tests show. You need to rule out inflammatory bowel disease like ulcerative colitis or Crohn's disease if there's some pain or if there's any bloody stools. Sometimes you might find signs of inflammation on the lab testing without those obvious symptoms. And if you do, it might be worth a visit to a gastroenterologist. There can be food allergies. There could be delayed effect food sensitivities. There can be an overgrowth of pathogenic bacteria. There can be an overgrowth of pathogenic yeast. There's so many things that could be going on in the gut that there's no way I can tell you what your son has, but if there are symptoms, they need to be checked out because there's likely a good explanation for it. And if your doctor's doesn't know how to look for it or doesn't believe that it's a problem, I would find a doctor who is willing to do the investigation. Dr. Natasha Campbell McBride links multiple nutrient deficiencies with epilepsy. Do you treat epilepsy with nutrient therapy? I'm not an expert at treating epilepsy with nutrient therapy, but there are a few nutrients that can be helpful for some people. So, yes, I do, but not at the expense of stopping anti-epileptic medication. Usually, I would recommend if someone is having frank seizures, they need to be on an anti-epileptic medicine, and then we can start trying nutrient therapies to see if we can reduce the amount of medicine they need or reduce the frequency of their seizures if they're having breakthrough seizures. But so yes, but not. I don't use nutrient therapy alone. Another good thing to consider for epilepsy is a dietary change, because a ketogenic diet can be very effective at controlling seizures. But that's something that needs to be done with the help of a doctor and a dietitian. In some cases, the ketogenic diet is started with a hospital admission, because there can be such rapid metabolic changes as you start that diet that a lot of neurologists like to have the person in the hospital for a few days while they do it. What about ADHD as a comorbid condition with ASD, especially with high-functioning ASD or Asperger's syndrome? Yeah, this is a good question, and it's and there's not an easy answer to it. Certainly, we see children on the spectrum who appear to be hyperactive and who have attention deficits. Can you have a concurrent diagnosis of ADHD and autism spectrum? My understanding is no, although, and that's from a purely academic viewpoint. If you look at the DSM criteria, I'm not sure that you're allowed to diagnose those at the same time, because I think that the hyperactive and attention symptoms might be under the umbrella of the autism spectrum disorder. However, there's certainly plenty of doctors in the field who do treat them as individual entities, and that's certainly a doctor's prerogative to do that. But I would also say that in someone who has an attention problem, that you need to look for a biological reason for that. Could there be a food allergy? Could there be a nutritional deficiency? Could there be additives in the diet that are known to cause attention problems, like artificial food colors and sodium benzoate? So there's certainly a lot of things that need to be ruled out before you jump to an ADHD diagnosis with anyone. Is there a list of gene mutations to look for when doing a full gene sequencing for the ASD child and the parents? Probably not. I really think that we're still just scratching the surface in terms of our understanding of the human genome. We have it fully sequenced now, but we don't have it fully understood. So there's definitely probably at least 100 genes, if not more, that have been correlated to the presence of developmental delay. But I doubt that we know everything there is to know about that. There are certainly some geneticists, though, who can give pretty well-informed information about how and why a certain genetic mutation might be playing a role, and there's always the possibility in some of those cases for intervention either through diet or nutrient therapy or pharmaceutical therapy. Gene therapy is still on the horizon. Let's see. I have a 24-hour EEG for my child. Is this valuable in ruling out many potential diseases that are similar to autism in presentation? How do I give this to someone experienced in this? Okay. So I take it to mean that you have the printout of the EEG, and or at least you have a report. Is it valuable in ruling out potential diseases similar to autism? Well, yes. I mean, seizure disorders in children usually come with intellectual deficiencies. You know, it does affect intellectual development, and so if there is a normal EEG, 24-hour EEG, that is a pretty good confirmation that there's not a seizure disorder. And but beyond that, I don't know that you know, I guess it's suggestive that perhaps there's also not a mitochondrial disorder, but that's not conclusive. Many people with mitochondrial disorders have seizures, but not all of them. So it's a 23-hour EEG is a great thing to have done for a child with autism, to rule out a seizure disorder, especially one that you may not have ever even suspected. But I don't know that it does much more than rule out seizure disorders. What about celiac disease and inflammatory bowel disease? Well, yeah, I touched on that a little bit already, but celiac disease, I don't have numbers just off the top of my head to know whether that's more prevalent in the autism population or not. But I would say in general, gluten intolerance, perhaps non-celiac gluten intolerance, I would suspect is a little more common in the autism population from my experience. Inflammatory bowel disease, is it more common? That's I suspect it is, but I don't have the numbers. It's definitely should be high on the list of something to look for and to rule out in any child on the spectrum. One of the first questions I got here, what role does the use of medications that induce mitochondrial dysfunction, such as metformin, glyburide, aspirin, acetaminophen, Lipitor, etc., have on the fetus if used during pregnancy? I suspect that it doesn't have a good effect. Whether it causes a mitochondrial disease or not, I don't know about that, but it could cause it may contribute to mitochondrial dysfunction, perhaps. I don't know that really has been looked at that closely. Studies of pregnant women are difficult to come by for obvious ethical reasons, but all I would say is adding to that list are certain antibiotics such as the tetracyclines and the macrolides such as erythromycin. Those can also have an adverse effect on mitochondria. So certainly anyone who has a diagnosed mitochondrial disease should have a list of these medicines that they need to stay away from because it can make their symptoms worse. Let's see. Boy, there's a lot of questions. That's great. Are there diets that mothers can utilize that would reduce the real-world incidence of autism spectrum disorders? Can such diets be individualized to various types of mothers with specific genetic disorders? Well, that's kind of off topic, but I would suspect that diet may have the ability to reduce incidence. Certainly there's a lot of doctors and clinicians out there who are working on prenatal care to reduce the incidence of autism. And usually a clean diet is recommended Certainly one that's whole foods based, free of herbicides, pesticides, artificial chemicals in general, and a lot of people also recommend a gluten-free diet during that time. But as far as hard data to support that, I don't think we have that yet. Any experience with osteopathic manipulations helping autism spectrum disorder kids? Well, this is obviously just a question because I'm an osteopath, and I appreciate that. Yes, there is experience. Yes, I do have experience to some extent with it, and some knowledge of it, and definitely there's a lot of cranial osteopaths that do report improvements in core symptoms, although not necessarily a long-lasting effect. So usually those doctors recommend doing it in conjunction with biomedical therapy as well. Here's a question: how does one get tested for PANDAS? As of right now, there's no firm diagnostic lab criteria for PANDAS, although checking strep antibodies can sometimes be helpful. But the absence of an elevated strep antibody doesn't rule it out, unfortunately. It's primarily a clinical diagnosis, which means that it's diagnosed by the doctor based on the history and the exam. You need to see a doctor who's familiar with what PANDAS is in order to get that done. What are the benefits of genetic testing? I think I went over that pretty well. Certainly there's going to be a lot of kids who test genetically normal who are on the spectrum, but there is a significant percentage who are going to have some abnormalities, and in some cases those just based on the known biochemical role that gene plays that's defective, there might be obvious therapeutic intervention to compensate for a genetic deficiency. What is the best test to assess zinc, magnesium, and vitamin B6 status? I usually assess zinc through a serum zinc and serum copper level, and look at that ratio. Magnesium is a little bit harder to assess via lab, but perhaps the best test is with a red blood cell level. And then vitamin B6, I usually diagnose it through a urine organic acids test. Where's a good place to start with genetic testing? Well, frequently a primary care physician will be able to order the test, and then if there are abnormalities, you get referred on to a genetic counselor or to a geneticist. And if your primary care doctor is not familiar with what genetic testing to do or isn't comfortable ordering it, then you could certainly schedule an appointment with a medical geneticist or a metabolic disease specialist. How can we proceed to have our children tested for learning disorders? I think that's best done through the school environment, although you could certainly independently take your child to a neuropsychiatric doctor where they perhaps could do that sort of testing. Do any of these comorbidities improve or worsen with age? Are there some that are seen in certain age groups? We have had GI and possible seizure issues in our 2 ASD boys and have done various treatments and diets with mixed success. Well, in terms of seizures and GI issues, do they improve with age? I mean, I usually see them improve with age, especially the GI issues, because they're being treated. You know, if you can diagnose and treat them, they typically will get better. In terms of seizures, that's I have a little bit less knowledge about that, and I would probably defer that question to a neurologist. But certainly seizures can change over time. Some people do seem to outgrow them, but I don't have a lot of data about that topic. Is fecal transplant an option to improve gut health? How close are we in getting it done in a relatively easy way? It does seem to be an option for improving gut health. There's certainly a lot of anecdotal information about that, showing improvements. Discussion among biomedical doctors seem to support that as well. And there's some limited scientific studies also showing benefits of it. How close are we in getting it done in a relatively easy way? I don't know. I know that there's definitely a group in Canada working on an oral form of it, that, not a non-disgusting method of doing it. We put it that way, and but how close they are, I don't know yet. I sure hope they are close, because I think it is a pretty valuable intervention if it can be done easily. Here's a great question. How can I determine if my son's GI issues are related to his autism? Is there a different treatment for his GI issues if there is a link to his autism? I don't know that you need to determine if they're related to his autism. The fact that they both exist is enough, I think. And if you, I think there probably is some connection, but I don't know that it's relevant. Generally, in my experience, if you treat GI issues, a person becomes happier, and nutrient status is going to improve, and pain is going to resolve, and it's going to have just a beneficial effect on behaviors and cognition in general. So, are these comorbid? This is a kind of a generalism of this question. Are these comorbidities that I've talked about related to autism? Do they have something to do with autism features? And to that I would say probably, with the understanding that autism is a diagnosis based on behaviors and not based on biochemical abnormalities. Right, so the diagnosis of autism actually doesn't say that much about what's going on inside the body. All it talks about is what we see on the outside. And so a diagnosis of autism is not all that informative, is what I'm getting at. And so I think you have to suspect biochemical problems inside the body, and that's going to be variable from person to person. So if you have someone on the spectrum with GI issues, there's a good chance that comorbidity, along with any others, is related. I'm afraid I'm going to have to wrap it up. Well, there were some really great questions here. And I appreciate everyone's attention and really thoughtful questions. It's been a pleasure talking to you today, and I hope I get to talk to you again sometime soon. Take care.